Very good morning to all. Today, I'll be presenting a journal titled as Financial Toxicity Among Older Mexican Adults with Cancer and Their Families. So financial toxicity is a broad term which includes expenses incurred by patients after cancer diagnosis and its impact on personal and family budget. It is an adverse event in oncology which has potential impact on the physical, social, and emotional function. It hampers treatment adherence as well as impairs quality of life of both patients as well as their relatives. This, in a systematic review, which looked at the financial burdens and its risk factors and outcomes, found that adherence to cancer treatment was poor, as there was among patients who had worse financial burden. A study from US reports that in patients who are aged 70 years and above with advanced cancer, the prevalence of financial toxicity was 20%, and it was a risk factor for distress as well as poor self-reported health. And though it was conducted among patients with Medicare coverage, the financial burden represents a key problem in low and middle income countries, and though yet studies haven't explored this issue. And these countries also lack public insurance programs to protect older adults and their families. There is limited availability of pension and social protection schemes. Hence, most of the older patients are dependent on their families, and financial toxicity of cancer generates amplifying effect, and economic stability, productivity, and income of the entire generations are affected. The hypothesis of this study was that a diagnosis of cancer in older adults in low and middle income countries causes significant financial toxicity for patients and their relatives or caregivers. The aim of this study was to explore and analyze the financial burden of cancer among older Mexican adults and their families and or caregivers, and to analyze the factors which might mitigate that burden. Coming to the methodology, it was a mixed method design, it included both quantitative as well as qualitative design. It was a multicentric cross-sectional study. The sampling was non-probability sampling, which means that the samples are selected according to the subjective judgment of the researcher. Considering that 72,792 patients aged 65 years and older are diagnosed with cancer yearly in Mexico, and assuming a 50% prevalence of financial toxicity, a sample size of 96 participants would have estimated the true population proportion with a margin of error of 0.1. They included patients aged 65 years and older with a diagnosis of 10 tumors with a higher incidence in Mexico between 3 to 24 months from diagnosis, and at least one relative who acted as their main informal caregiver and accepted to participate. The interviews were either face-to-face or conducted remotely through video conferencing due to COVID pandemic. For the quantitative measures included the demographic details, and financial toxicity was assessed using the Spanish version of comprehensive score for financial toxicity, functional assessment of chronic illness therapy, also called as cost-facet version 2. It is a 12-item scale, which is of Likert type. Each question is scored between 0 to 4, and the total score ranged between 0 to 44. It is 44 and not 48 because the 12th question is not taken into consideration while calculating the score. And the score is graded as more than equal to 26, having no impact on quality of life, 14 to 25 having mild impact, 1 to 13 having moderate impact, and 0 having high impact. So this is the scale, and each question is scored between 0 to 4. And we'll see that there is mixed response actually, like the question 2, 3, 4, 5, and 8, 9, 10. These have a negative impact. So the scores have to be reversed up for these questions. And only up to 11, the sum is added up. And to assess the capability of undertaking unexpected expenses, impact of financial constraints over daily activities and personal well-being, the Spanish version of Consumer Financial Protection Bureau Financial Well-being Scale was used. It is a 10 items questionnaire with the score ranging between 0 to 100 points, and the lower score meant a worse financial well-being. For out of pocket spending for previous 3 months was quantified using self-reported cost diaries. So this is the financial well-being score. Again here, these are 10 questions and a total response is measured. And based on that, they get a total score. I'll show you an example of the score sheet. Here, the person who has entered gets a total score of 12 as a response. So from here, they derive a total score based on this. Since the person who entered it, self-administered it, and was between 18 to 61 years of age, under this column, he got a score of 12. So the well-being score will be 40. So this is how the score is calculated for the individuals. So if the person was above 62 and above, then we would look at this column. If it was self-administered, if it was administered by someone else, then we would look at this column here. So for qualitative component, 25 patients were selected from the 96 patients and the relatives were also interviewed. The methodology was based on an approach to investigate and describe the individual experience of each patient and relative. Interview was conducted by a trained psychologist with previous experience in conducting qualitative research, and it was a face-to-face interview in a room in outpatient psychology clinic. The audio was recorded and transcribed for analysis. So previously developed interview guides were used and questions on the physical, cognitive, psychological, and economic aspects faced by patients and the relatives were assessed. The various categories related to the impact of financial burden, the patient and family level variables, the social and cultural norms influencing the patient and the relatives, societal and national factors related to available instruments for supporting the patient, the employment status, existing debt, available assets, consequences of the disease on the current employment, insurance, availability of insurance, economic support were also evaluated. Specific out-of-pocket expenditure and its effect on the provision of basic supports and supplies were also assessed, and patients and relatives were also asked to discuss the strategies to mitigate financial burden, utilization of governmental or non-governmental social program, and potential solutions they may consider useful. So the descriptive statistics for measurement of the variables, and for the qualitative components, a descriptive analytical procedure included categorization, coding, ordering and classification, establishing relationship and causal network, and interpretive models were used. So coming to the baseline characteristics, the mean age of the patients was 72.1, 40.6% of them were women. The average distance between the patient's home and the hospital was 80.8 miles, and 30% did not have any health coverage, and only 2%, as expected, had private insurance, and the rest of them either had a catastrophic expense fund or social insurance program. Among the current employing status, only 6% of the patients were currently employed. The monthly income of the family was $122.6, and the number of persons contributing to the family income was 1.7 people. The distribution of cancer was prostate at 33.3, colon was 13 people, breast 12 patients, lung cancer 10 patients, liver cancer 8, gastric was 7, pancreatic 5, endometrial and ovary was 5, lymphoma was 3, and cervix was 1. This was predetermined. And the time since diagnosis, the average time since diagnosis was 20.5 months. The result of the quantitative component of the study shows that the cost facet, the mean score was 16.4, and only 9% did not have a financial toxicity, whereas 52% of them experienced mild financial toxicity and 39% reported moderate financial toxicity. For financial well-being of the patient, from the patients, the mean score was 45.2, and 78% of them reported poor financial well-being, whereas when relatives reported, though the mean score was same as the patient, which was 46.8, only 56% of them reported poor financial well-being, as compared to 78 among the patients. The self-reported monthly income was monthly patient's income was $178, whereas the household income was $661, and the total expenditure was 1,994 US dollars. Most of it went on medical treatment, including chemotherapy, which was followed by the orange, which is laboratory studies and imaging, followed by the yellow, that is medical consultation and transportation. The least was spent on accommodation. For the qualitative component, the relatives' mean age was 55.9, 88% of them were women, 48 were patients' daughters or sons, and 44 were partners, and 8 were siblings. Employment status, 44% of them were homemakers, 28 of them had office occupation, 16% had service occupation, 12% had sales occupation, and 4% had production occupation. When asked regarding health status prior to cancer diagnosis, most mentioned that they had chronic conditions such as diabetes, hypertension, and heart problems. Though for some it was controlled, others complained that these comorbidities added to the complications from cancer. Regarding the financial situation before cancer, most of them reported a low socioeconomic status, and they also said that they had low or irregular incomes. Regarding assets, there was very few people who owned a house or a piece of land, and only one of them reported that they had a pair of cows as assets. That most did not have any debt before the diagnosis of cancer, though they did mention that they had limited incomes. For history of seeking for treatment, time between the first symptom and diagnosis was variable, and it varied between weeks to more than 1 year. And when they were asked regarding the factors which were influencing in the delay in treatment, most of them said that it was because of cost or bureaucracy related to the diagnostic tests, ineffective medical care, or saturation of the public health services, which led to the delay in diagnosis and treatment. Regarding the out-of-pocket expenses, the cost of studies and treatment was paid by either the patient or the relative. The transportation and travel expenses were frequent, and few had to travel even up to 180 miles to find cancer care. The impact of illness in the patient's productivity was that patients had to frequently quit their jobs, and few had to even move to the Mexico City to receive treatment. The impact of the illness on the impact of illness on family productivity was inquired. There were repercussions of the illness on the caregivers and relatives, but they did not perceive the economic cost as a burden. Though illness has changed they said that the illness had changed their routines, expenses, and the order of their own personal needs. Regarding expenses related to comorbidities, they most frequently were spent on either management of diabetes or hypertension. Regarding the financial situation, the personal and family finances, the cancer diagnosis impacted the entire family's economy, and they had to reduce their excessive spending. The source of income varied from one family to another, and the patients less commonly had a job. Hence, source of income either for the patient was either the financial support program by the Mexican government or retirement pension. Regarding the current deaths, most patients and relatives reported multiple deaths from either banks or retail shops who gave credits at high interest, and deaths from borrowing money from other relatives. Regarding the expense management strategies, most of them relied on their savings or on selling assets. When asked regarding solutions seen by patients and relatives which could mitigate the financial impact, the free access to medical treatment or adjusting the cost according to the economic status of the patient was one of them. The other points which were mentioned included payments through non-profit organizations, improvement in organization of services and appointments, especially for those who are living in faraway places from cancer centers, and government investment in the medical infrastructure to improve the public health services, which was one of the factors which led to the delay in the diagnosis as well as treatment, and programs for older adults, as well as flexibility in caregivers' job, because most complained that one of the issues was that the caregivers could not manage job as well as taking the patient to the cancer centers. The strength of the study would be that it is a first of its kind from a low and middle income countries, because most of these studies which are conducted to assess or evaluate the financial burdens were done in the higher income country groups, and also these countries have some form of a insurance program, and this was one of the first in a low and middle income country. Its mixed method design, which resulted in a comprehensive view of the financial problem as compared to only conducting a quantitative or qualitative study. It provided an overview of financial toxicity among a heterogeneous sample of patients, unlike some few studies which were conducted only in patients with a particular type of cancer. The limitations would include the cross-sectional design, which could not identify specific factors which were associated with financial toxicity, a recall bias, which caused trouble in remembering the expenses retrospectively, as well as it may not reflect the patients seen in smaller hospitals. Coming to the critical appraisal, this is a critical appraisal of only for the qualitative part. So was a qualitative approach appropriate? Yes, it was appropriate. Was the sampling strategy appropriate for the approach? Yes, it was. Were the data collection methods appropriate? Yes, it was appropriate. Is the researcher's position described? Yes, it was described. Do the results make sense? Yes, they do. And are the conclusions drawn justified by the results? Yes, they are justified. So to conclude, this study reports among Mexican older adults with cancer and their relatives a high prevalence of financial toxicity and poor financial well-being. Understanding individual experiences with financial toxicity of cancer among patients and relatives is an essential step to design public health policies. Thank you.
So thank you, Abhijit, for the crisp presentation. So, what do you suggest? Yeah, a study on financial toxicity in this way can be done in our institute as well. What is your thought?
So can it be done in
our institute?
Yes, sir. It can be done, and I'm not sure if it has. I didn't find any studies, but I think yes, sir, we should have data on financial burden as well as financial well-being among our populations as well, sir. Because we do see patients coming from very far away, so that would give a good insight into their troubles, especially the qualitative part, and not just the quantitative part, sir.
Yeah. So I think for the qualitative part, we required psychologists in this study, correct?
They have, yes, sir. Use psychologists, sir.
So that is the only issue which we might not be harboring. So, while doing geriatric assessment, do we include any tool to include financial toxicity or financial assessment of the patient?
We do include the caregiver burden scale, sir, which asks some questions are regarding the financial burden faced by the caregiver, but we don't specifically look at financial toxicity, sir. We are not looking at it separately. As a part of caregiver burden, there are one or two questions on that.
Okay.
And also on financial well-being, sir. There are a few questions on that.
Yeah. While assessing the financial status of the patient is really important while deciding the treatment options, because sometimes adding of 1 or 2 months of life might be useful for some patient, while it might lead to more destruction in the entire family for another patient. So that is what we need to understand and look about. For example, just giving an example of cetuximab, when I counsel a patient that addition of cetuximab to the treatment, to the therapy, will add a few months of progression-free survival. One patient told it will be difficult for me. The relatives were willing initially, but when I explained the long-term implication and the cost, they told they are not willing for it. That patient who was not looking affordable even, but when I counseled, the relatives told no, they will get some specific reimbursement and they want to get this. Even 1 month of addition of life is important for them because they have a family function and they want the relative to attend the family function at any cost. So implications of life and finances are different for different patients, and this must be implicated and understood clearly. The way we think, we should not decide. We should leave it to the family and the patients and the responsible caregivers for them to decide. And I think sometimes we tend to take decisions by the look of the patient, and we have already realized this from the geriatric clinic that the look of the patient might be fallacious and the actual status might be different. A patient who is looking very fit might have suffered significant falls in the last 6 months, and he might not be a candidate of multi-agent full dose chemotherapy. So that is what we have learned from the geriatric clinic under the leadership of Anita ma'am, and this is very important. Similar for financial toxicity, we should have some methods. That is why we try to send every patient to social worker. So social workers do the estimates of the finances, and they themselves recommend which support program the patient can be enrolled in. So this is a part which is being done at all the TMS centers by the medical social workers. So I think their involvement in every patient is really necessary, especially in patients who are not very literate, because that is very important. Any comments from any comments from the other faculties, or are there any questions? Amit Joshi sir, any comments?
I think it's a different perspective in a cancer therapy management, at least in the palliative setting, the financial aspect. So, and only thing is that this is one of the model which has been used, but there are certain perspective which are different in our socio-economic scenario or social scenario than the Western world. So I think ideally there should be a score which is developed, and I think since Abhijit is working in the his core area is geriatrics, so we should ultimately have some more. So we have the Western. These are the questions which are more pertinent to the Western world scenario. How these questions and how our patient, I am not sure about that, because the social dynamics, the family support, the family value, life value. So it's not a question just only for a social issues. The psychological and all that also plays an important role in the economical aspect for a. So from a clinician point of view, what we should that at least in a scenario where the benefit is not more, we should discuss with the patient what Akhil has said, the real perspective. Sometimes the patient and family may have a guilty feeling that we don't have a money. We could have, if we could have money, we could have given that drug X, drug Y. But if the benefit of that drug is not that substantial, we should discuss with the patient in a way that they should not feel that because of the monetary benefit, their patient is not getting the treatment. So generally we discuss that although these are the new drugs available, but the cost benefit ratio doesn't favor much in the favor of that drug. The cost is so much, the benefit is in only months. So definitely we have to take the direction in the and we when we know that patient is not going to afford, we should just touch that aspect of that there is a treatment, but the relative benefit of that treatment is not proportional to the cost of that therapy and may affect the quality of life. So we have to be a little bit careful when we are talking patient in a when we are seeing patient in a general OPD vis-a-vis in a private side. But definitely as a legally we have to explain to the poor patient also, but we should not stress, because it's not only the financial impact, is the psychological impact, not only in the patient but their caregiver, and with the guilt that the money is the constraint their patient is not being treated. And definitely the question needs to be, if we want to know our exact, then the question needs to be a little bit modified, which is pertinent to our socioeconomic. But definitely it is one of the way to assess this final toxicity in our patients. So good presentation.
Yes, completely agree, sir. So we need to be careful while explaining the way we explain. So this is very important point, and this is one of the art of oncology which we learn with time. So this cannot be learned from the books. This can be learned from watching our seniors explaining the patients and the relatives, the counseling which is being given. So this is one of the art of the oncology or art of oncology, and it comes by the practice and visualization of the seniors. So it becomes our responsibility to train our juniors so that they can explain the patient and the relatives in a way that is the most conducive. It does not hurt the sentiments. At the same time, gives the best possible information to the patient and relatives about the treatment outcomes and the treatment options. So definitely we need to consider this. Regarding the applicability of this questionnaire in Indian setting, sir, we had a discussion with Dr. Enrique Soto, who is one of the co-author of the study. So, it was conducted in Mexico. Mexico is also a lot like India only, not much high class people, but not many patients who are insured. So, insurance level is also low in Mexico. So it was somewhat fine. That is why they included qualitative part, which was beyond the questionnaire. So they had recorded the questionnaire, the interview or qualitative interview by the psychologist, and they took the points so that they can get a better idea, not just a questionnaire, fixed questionnaire which was developed in the West. So that is why they included qualitative interview as well.
Again, this questionnaire has been validated in Hindi and Marathi by Devansi, one of the MSc student, and it has been incorporated in the website also. So if you want to use the Hindi version, this has been validated, and the cost facet has accepted that. So you want whatever available, you can start using, because it has been validated and it is available in the cost facet website, Hindi and Marathi. So for you, the Hindi version may be helpful in assessing this kind of a study. You can do in your setup. So it's a one-time follow-up. You can discuss with this. So I think this version is available in Hindi and Marathi.
Okay, sir. Great, sir. So this is actually useful. When we do such analysis, then only we can understand it better. So experience is one part, and doing a proper assessment is another part. So these are very important, and a way to understand our patient population better. So, any other comments or question? Kumar sir, any comments from your side?
No, thank you, Akhil. This was a nice discussion, and I know some data from Abhijit in future will help us know it more. Individually, we all do what you said, and absolutely that is very important that we keep doing it. But scientifically, to keep understanding is also important, and hope Abhijit and you do some activity in this. And again, important is tools. There are tools. There is no one tool to do science, and my tool can be different from your tool. Here I'm saying from Western tool, but I know, and there's no perfect tool also, but some tool can be used to know the same question. So no, I enjoyed it. Thank you.
Thank you. Any other comments or questions?
I'll give you one example of it, where the tool can go really haywire, because there is a time today, so one can have this kind of discussion. Someone can try to put in Google. There is a Dr. Saab called Dr. Prinja, very famous guy from PGI. He has done quali analysis. Well, quali is one way to know the cost and how it benefits patient, isn't it? Am I right, Abhijit?
Yes, sir.
Correct?
Yes, sir.
Correct, na? So put Dr. Prinja's name and put for temozolomide. He has done the analysis. And someone can put it up. Isko hata do, Abhijit. And someone can, Abhijit, can you put Dr. Prinja's name and put Quali and put temozolomide? So मैं भी try करता हूँ. तब तक in the meantime. कुछ मिला क्या किसी को? नहीं
सर मिला शंकर
बहुत. उसका एब्स्ट्रैक्ट ही सिर्फ एब्स्ट्रैक्ट दिखा दो उसका.
ओके सर जस्ट करेक्ट वन सर.
एब्स्ट्रैक्ट दिखा है?
हाँ सर.
पब्लिश्ड है ये पेपर. Go down, keep going now. बहुत बढ़िया, बहुत ही बढ़िया. Incremental cost per quali, which is 4% probably cost effective at one time. In this case, the price should be decreased by 90%. बहुत बढ़िया. तो कोई बताएगा ये temozolomide का कॉस्ट कितना है पर मंथ आज के टाइम में? मैंने पता किया था उस टाइम पे कितना था. बाय द वे, एनीवन कैन. मैं तो देखो ज्यादा ट्रीट करता नहीं.
With concurrent treatment which we are using, the cost
is a palliative वाला है ना?
हाँ सर
palliative वाला है. तो कितना पर मंथ कितना कॉस्ट आता है temozolomide का?
Consequences of treating GVM with radiation alone versus radiation with
अच्छा रेडिएशन के साथ में. चलो वो भी बहुत बढ़िया. तो रेडिएशन के साथ कितना आ जाएगा कॉस्ट?
मंथली कॉस्ट सर 2500 से ज्यादा नहीं होता सर.
2500 का कॉस्ट है. अब देखो डॉक्टर साहब क्या बोलते हैं यहाँ पे. डॉक्टर साहब बोलते हैं डिक्रीज शुड बी डिक्रीज बाय 90%. सो व्हाट ही मींस द कॉस्ट देन? गेस करो अभिजीत. अगर 90% कॉस्ट निकाल दे 2000 में से, पर मंथ का कॉस्ट निकाल दें तो कितना बच जाएगा कॉस्ट पर मंथ?
200 बच जाएगा.
200 रुपीज. अब मुझे कोई ये बताए कि भाई ये 200 रुपीज में temozolomide बना के कौन देगा इस देश में? अब देखो ये प्रॉब्लम है टूल का. अब साहब ने तो टूल यूज कर लिया. And again, nothing wrong against him. Say he has his own scientific bent of mind. He understands that part of it. I never has interacted directly with him. In fact, my friend Vijay is also part of the authorship, and that's why I know in detail. And that time he went on talking to me, should I be part of authorship or not? And for me, it was that, hey, be part of it, because that way you have a chance to put your point forward. And he did point this point forward. कि डॉक्टर साहब आपने तो लिख तो रहे हो, ये ऐसे कोई देखने वाला तो है नहीं, कोई ना गवर्नमेंट ऑफ इंडिया ने ये लेते हैं जो हम करके देते हैं. But having said that, think about a policy maker takes this, and वो बोलते हैं कि either you make temozolomide at 200 rupees or you are not going to make it. That is what it means. Or at least Ayushman, government of India, state government, Maharashtra government, they are not going to pay for it. Correct?
Correct.
अब मुझे कोई बताएगी कि आप ये बताओ इसकी कॉस्ट बनाने की क्या होगी. I do agree, we need to criticize कि देखो ऑसिमटनी बनाने की कॉस्ट कितनी है और आप 4 लाख में बेचते हो. I do agree, that is one criticism. But then has to be seen other side. कि अगर मान लो कि हमें चाहते हैं कि अगर कोई हॉस्पिटल रन करे, the unless hospital, now Tata Hospital runs, DA gives money, and then also we charge our private patient. करेक्ट ना अखिल? तुम्हारे अभी चार्ज लेते हैं ना? लेते हैं. अब देखो, अब मुझे बता दो कि 200 रुपए में कौन temozolomide बना के देगा? अब 6TG अवेलेबल है मार्केट में?
नहीं सर, हट गया।
नहीं ना, बहुत बढ़िया। 5FU मिलने में दिक्कत होती है?
यस सर, बीच बीच में होती है।
तो ये एक बड़ी इंपॉर्टेंट चीज है। अब इसको अगर जानना है तो एक किसी और ने सीखना है, अगर टाइम है तो एक काम कर सकते हैं, है टाइम? हाँ टाइम। अभिजीत नाइस में चले जाओ, नाइस में सुनिटिव डालने के लिए। नाइस गाइडलाइन डालोगे और सुनिटिव डालोगे, ठीक है? तो उसकी जो डिस्कशन हुई थी गाइडलाइन में नाइस की सुनिटिव के लिए, वो पढ़ने के लिए, और वो भी क्वाली पे ही है।
Overview of first line treatment of advanced or metastatic renal cell carcinoma.
नाइस गाइडलाइन है ना? करेक्ट?
Guidance.
गाइडेंस है ना? हाँ, गाइडेंस को ओपन कर दो तो यू विल सी इट कि उसकी गाइडेंस में क्या डिस्कशन हुई थी।
Same as. सेल्फ पे गाइडेंस क्लिक करना है।
हाँ, गाइडेंस पे दिस गाइडलाइन एविडेंस बेस्ड रिकमेंडेशन में डालो गाइडेंस में। नहीं, इसकी बड़ी अच्छी डिस्कशन है, बहुत ही बढ़िया डिस्कशन है। हर एक को पढ़ना चाहिए जिसको भी थोड़ा भी इंटरेस्ट है कि हम कैसे कॉस्ट को और इफेक्टिवनेस को हम लाते हैं क्लिनिक में। एंड आई शोड यू वन same tool. When you use bluntly, what happens? Thankfully no one adopted it, otherwise तो टिमोजोलोमाइड तो रहते नहीं आपके। अखिल तुम तो लिख ही नहीं पाते भाई, और हमारे यहाँ भी हम नहीं लिख पाते क्योंकि वो तो प्रिंजा साहब ने बताया कि 200 रुपए का जब तक आता नहीं है तब तक तो आप यूज कर नहीं सकते। अभी बहुत बढ़िया, हाँ अभी देखो बहुत बढ़िया। अब इसको चलते जाओ, नीचे चलते जाओ, इसको नीचे 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 आराम से धीरे धीरे जाना, धीरे धीरे जाना, धीरे धीरे जाना, धीरे धीरे जाना, धीरे धीरे चलते जाओ, धीरे धीरे चलते जाओ। बहुत बढ़िया, बहुत बढ़िया। पहले क्या है, उन्होंने क्या लिखा? बिल्कुल क्वाली ही है, क्या है? मैन्युफैक्चरर्स टूल। चलो नीचे जाओ धीरे धीरे, एक मिनट रुक जाओ, फिर से एक मिनट। उन्होंने क्या? असेसमेंट ग्रुप मॉडल का टूल। ये भी देखो क्वाली है, ये क्वाली हो रहा है, यहां कोई दूसरा चेंज नहीं हो रहा है। नीचे जाओ, नीचे जाओ, नीचे जाओ। फिर उन्होंने क्या? हाँ एक मिनट, वैलिडिटी चेक फॉर पेशेंट्स डेटा बाय डिसीजन सपोर्ट यूनिट। उन्होंने फिर फाइजर से मांगी कि भाई आप जो पेशेंट्स के जो नहीं हुए क्रॉसओवर, उनका डेटा और क्रॉसओवर डेटा अलग दे। नेक्स्ट जाओ, बहुत बढ़िया। एक मिनट, असेसमेंट ग्रुप मॉडलिंग ऑफ कमिटी प्रेफर्ड assumption टेकिंग इनटू अकाउंट रेस्पॉन्सेस फ्रॉम कंसल्टेशन। अभी कंसल्टेशन किसके साथ हुई? देखोगे थोड़ा सा, इसको थोड़ा सा पढ़ोगे।
Yes, sir. So DSC were requested to use the following assumption in the manufacturer's model: 12.72 months and 20.88 months PFS for the interferon alpha and sunitinib arms respectively. 2.29 life years overall survival for the interferon alpha and sunitinib arms respectively. All the data were from the final intention to treat analysis except for the OS data for the interferon alpha arm, which was from the no post-study treatment group. Using this data in the manufacturer's model resulted in ICER of 49,000 pounds per query gained from sunitinib compared with interferon alpha.
अच्छा, जो मैंने शुरू में दिखाया नहीं, अब ये 49,000 था, स्टार्ट में शायद 60 या 70,000 था। ऊपर जाके देखना, ऊपर भी देखना थोड़ा सा, जिससे कि वी अंडरस्टैंड कि देखो भाई कैसे कैलकुलेट करके कैसे आया। बहुत बढ़िया, बहुत बढ़िया। यहाँ देखो 30,000 दिख रहा है, यहाँ 35,000 दिख रहा है पर क्वाली। ऊपर जाते जाओ, यहाँ देखो एक मिनट, यहाँ 72,000 दिख रहा है, 71,000 दिख रहा है। सर नीचे आते जाओ, अब नीचे आते जाओ, वापस नीचे आते जाओ, नीचे आते जाओ, नीचे जाते जाओ, हाँ अब नीचे थोड़ा सा नीचे जाओ, बहुत बढ़िया, और नीचे जाओ, एक मिनट, बस बस एक मिनट, अरे अभिजीत तुम फास्ट फॉरवर्ड हो, यंग लड़के हो, लेकिन थोड़ा टाइम तो दोगे हमें, बूढ़े लोगों को भी। हाँ अभी आंख भी नहीं काम करती ठीक से। Appraisal committee clinical evidence of the nature of condition and value on the benefit of sunitinib by people. Committee heard clinical specialist. Committee heard whom? Clinical specialist. अब ये प्रिंजा साहब से पूछा जाना चाहिए कि देखो साहब आपने किसी क्लिनिकल स्पेशलिस्ट से बात की, और जिससे बात की उसकी बात को तो आपने माना नहीं। अब देखो यहाँ पर आई थिंक सो विजय भी है अभी इसमें। विजय तुम हो क्या? मैं देखा तो थे। ओके एनीवे, जब इन केस विजय वांट्स टू स्पीक देन ही कैन। उसके बाद क्या उन्होंने लिखा है? पेशेंट्स एक्सपर्ट। अब उन्होंने भाई पेशेंट एक्सपर्ट से बात की क्या? अब देखो ना, तो अब उन्होंने क्या सुना? दैट देयर आर लिमिटेड ट्रीटमेंट ऑप्शन ऑफ द पेशेंट विद एडवांस एंड मेटास्टेटिक डिजीज। द कमिटी नोटेड the only current standard of treatment is immunotherapy, that is time वहां पे कि इंटरफेरॉन और इंटरल्यूकिन था, and there is no current treatment option for people whose condition have failed to respond to immunotherapy. The committee heard from people with RCC. What committee did? Committee heard from people with RCC, not sitting in the AC room and calculating quality. वो भी AC room में ही बात किया होगा उन्होंने भी, ऐसा नहीं है, लेकिन बात तो किया होगा। जिन्होंने लिखा कि उन्होंने बात की थी। Committee also heard that RCC does not respond well to conventional chemotherapy. The committee noted that the comment received that some individual patient experienced clinical benefit from this drug, and that life of people with RCC has been extended for a number of years following treatment with sunitinib. अभी देखो किसी को पता है कि sunitinib median progression free survival OS improve करता है? कोई थर्ड ईयर है हमारे यहाँ पे, राहुल, सुनिटिनिब ओवरऑल सर्वाइवल इंक्रीज करता है क्या? अगर रैंडमाइज ट्रायल में कहीं प्रूवन है क्या? अरे राहुल बोलते नहीं हो, मेरे थर्ड ईयर मेरे ओपीडी में नहीं बैठते और यहाँ भी नहीं बोलते जब भी मैं बोलता हूँ। हाँ राहुल थैंक यू। हाँ भाई, वो रैंडमाइज ट्रायल में सर्वाइवल इंप्रूव हुई थी क्या क्लिनिकली एंड स्टैटिस्टिकली? वो ट्रायल सर्वाइवल के लिए पॉजिटिव था या नेगेटिव था? अरे राहुल कुछ बोलता ही नहीं है। वो बोलता है सर आजकल तो इम्यूनोथेरेपी यूज करते हैं, आपके जमाने की बात है, वो आप लोग करते होंगे, वो ओल्डर ड्रग यूज, अभी तो क्या ही है। अच्छा चलो मैं देखता हूँ कोई समवन हु इज विलिंग टू स्पीक माय लैंग्वेज। प्रीतेश तुम हो क्या? प्रीतेश भी नहीं।
हेलो
हाय प्रीतेश। अच्छा देखो एक ही स्टडी हुआ था सुनिटिनिब का जो कि इंटरफेरॉन से कंपैरिजन में था। उस ट्रायल में क्या ओवरऑल सर्वाइवल पॉजिटिव था या नहीं था?
पीएफएस बेनिफिट ऑफ 5 मंथ्स।
ओएस मैं पूछता हूँ तो देखो पीएफएस बोलते हो ये
नहीं सर,
अच्छा नहीं था। अब देखो कमिटी ने क्या किया? दे हर्ड इट आउट and they did acknowledge that patients saying that okay there are group of people who lives longer. अभी आगे नीचे जाओ, थोड़ा नहीं ज्यादा मत जाना। Committee heard from people with the patient that expert and then okay significant improvement in their quality of life as a result of using sunitinib. अब ये बताओ भाई उस ट्रायल में क्वालिटी ऑफ लाइफ इंप्रूव हुई थी? अब तो बताया नहीं भाई कोई।
नो।
अच्छा तो अब देखो उसमें तो आए नहीं, नीचे जाओ फिर से। उसके बाद कमिटी ने सो व्हाट आई एम सजेस्टिंग सेइंग दैट कि देखो कॉस्ट एंड द ट्रीटमेंट की जो टूल्स हैं वन कैन यूज एनी ऑफ द टूल बट हाउ डू यू यूज इट? I know Abhijit unless someone wants to read more you can go through it, otherwise you can leave it. What I was suggesting that simply putting a tool and hoping, and we have done it. What we did, we early palliative care के लिए we used the tool as a quality of life to evaluate palliative care. That was a negative study, but we did not conclude in our paper. ये JNCI में paper है हमारा, Tata Hospital से our group did that. We did not conclude that early palliative care doesn't benefit the patient. क्यों? क्योंकि हमने देखा हुआ है, हमने न्यूट्रिशन सपोर्ट पेशेंट को देखा है वेट इंक्रीज हुआ, हमने पेन किलर दिया है, पेशेंट को देखा है पेन इंप्रूव हुआ, तो आइडिया इज दैट यू हैव टू बी केयरफुल अबाउट इट कि आपने क्या टूल यूज किया, क्या आउटकम है, और उस टूल का क्या वो जो मीनिंग हमें बता रहा है वो क्या सही है कि नहीं. नाइस डिसाइडेड कि क्वाली in this aspect it was not an absolute tool, it was a suggestive tool which showed them quality of 70,000 to 30,000. अब इसको क्वालिटी थी. हाउ डिड दे डू इट? बहुत अच्छा इंटरेस्टिंग है, समझ इसमें थोड़ा टाइम लगेगा, पढ़ने में काफी लंबा है. यू विल रियलाइज नो दे वर सेंसिटिव इनफ टू अंडरस्टैंड कि देखो भाई आप रैंडमाइज करते हो तो क्रॉसओवर करते हो तो उसकी अलग प्रॉब्लम आ जाती है. वो सारी चीजें फैक्टर होनी चाहिए. क्लिनिशियन जो ट्रीट कर रहा है उसको सुनना चाहिए, जो पेशेंट ट्रीटमेंट ले रहा है उसकी बातें सुननी चाहिए. देन यू कैलकुलेट कि हम कौन सा टूल यूज करके हम जो बोलना चाह रहे हैं पब्लिक डोमेन में क्या होगा. नहीं तो क्या हो जाएगा, वो डॉक्टर प्रिंजा साहब हैं, बहुत बढ़िया पेपर में आएगा कि नहीं देखो भाई ये तो 200 रुपए में बननी चाहिए टिमोजोलामाइड, ये अलग बात है, वो कभी बनेगी नहीं और कभी मार्केट में आएगी नहीं, 200 रुपए में कोई बनाएगा नहीं. तो ये एक इंपॉर्टेंट चीज है जब हम टूल को यूज करते हैं एंड सही तरीके से सेंसिटिव होकर कैसे करते हैं. नहीं तो हम बिजली फ्री दे देंगे, पेट्रोल फ्री दे देंगे, अब उसका तो देखो कोई लिमिट नहीं है, वो हर एक को पसंद तो आती है, बट वी ऑल नो कि जब ऐसा करते हैं तो क्या होता है. पता उसका बेस्ट एग्जांपल क्या है पेट्रोल फ्री और बिजली फ्री देने का? किसी को पढ़ना है तो पढ़ना. वेनेजुएला है ना, वेनेजुएला है, उसमें उसके पास दुनिया का सबसे ज्यादा पेट्रोल है. दुनिया का सबसे ज्यादा पेट्रोल मिडिल ईस्ट में नहीं है. इंडिविजुअल कंट्री वाइज दुनिया का सबसे ज्यादा पेट्रोल वेनेजुएला के पास है. एंड अभी हालत यह है कि लोगों को खाने को नहीं मिलता वहां. तो व्हाट वी डू विल रिफ्लेक्ट इन द सोसाइटी. एंड व्हाट वी आर स्ट्रगलिंग विद, मेथोट्रेक्सेट टैबलेट मिलनी मुश्किल होती है क्योंकि वो 5 रुपए में कोई बनाना नहीं चाहता. आप करते रहो कि हम सस्ता करेंगे, बट सस्ते की भी I totally agree. Osimertinib needs to be criticized. 4 लाख रुपए की osimertinib absolutely needs to be criticized. But temozolomide का interpretation which I showed you, I really want someone to convince me कि वो क्या सही है अगर हम public domain में डालते हैं. ठीक है, just talking about the tools क्योंकि time था आज तो I took some time और मैं ज्यादा नहीं लूंगा. Anyone, I'll happy to hear from other people what they think about. Thank you Abhijit, and thank you Akhil.
Thank you.
I think in the same note, Kumar, the cisplatin, the original cisplatin and carboplatin, which I think we, because of this issue, the BMS I think stopped, and we all know that the at least in ovarian cancer patient or a curable setting, the benefit of although it's not documented every anywhere, but we all know that the original molecule which we used to the cisplatin and carboplatin has a definitely a different response. So I think he explained very well about the absoluteness. So no tool is absolute. It is relative. So if you cut down the cost, whether it is really sustainable for the system to really use in or not. So that decision should not be taken by one tool. That was I'm mentioning for cost facet also. So it should be a relatively country specific, region is specific, and the socio-economic and psychological aspect also comes into all these factors. So I think it's a very nice explanation given by Dr. Kumar for this quali, which is in every case we say that do quali, but whether it is really applicable in our scenario, that has a real questions in that.
Thank you, Dr. Amit. And regarding that temozolomide paper, I had taken permission from Vijay for discussion, so don't get me wrong.